The American Society for Gastrointestinal Endoscopy welcomes you to a podcast featuring a conversation with Dr. Douglas Adler, GIE Associate Editor, and the author of a noteworthy article published in GIE Gastrointestinal Endoscopy. Each month, this podcast will feature an insightful conversation with authors of recently published articles in the journal. We hope that you enjoy the discussion.
Okay, everybody, welcome to this month's Gastrointestinal Endoscopy podcast. I'm Doug Adler from the University of Utah in Salt Lake City. I'm a professor of medicine there, and I'm also a senior associate editor for Gastrointestinal Endoscopy. And our guest this month is none other than the editor-in-chief of Gastrointestinal Endoscopy, Michael Wallace. Mike is a professor of medicine at Mayo Clinic in Jacksonville, Florida. Mike, welcome.
Doug, thanks. It's great to be here. It's a real pleasure to do the podcast together with you.
And ordinarily on the podcast, we typically cover an article, sort of break it down from soup to nuts. But this month, we're going to do something a little bit different. We're going to talk about EMR and ESD, which I know is a big part of your practice. I do a lot of ERCP, a lot of regular and interventional EUS, and I do a fair bit of EMR myself, but I think you definitely are more in this space than I am, and certainly more than most of our listeners. So just to sort of give us a little background, how many EMR, ESD cases do you typically do, say, for example, in a month?
So I have one dedicated day per week, which is just my complex endoscopic procedures, EUSs and EMRs, and then I have another half day a week that is purely EMRs. And so typically in a month, on each of those days, I'll do 2 to 3 on my full day and 1 or 2 on my half day, and the rest of them are follow-ups, which these patients come in every 6 to 12 months for the next 18 months. So the rest of them are follow-ups. So
where you're looking for recurrence and treating if it develops.
Right. So overall, I'll do about 10 to 15 a month. And my practice is still about 90% EMR and about 10% ESD. I'm pretty selective about doing ESD.
Mm-hmm. And then what would you say your breakdown of locations is?
The vast majority are in the colon. So these are large, flat, or lateral spreading polyps of the colon. And in the proximal colon, my practice is almost exclusively EMR. I do ESD more in the rectum, which we can talk about why that is. I do quite a bit of Barrett's associated EMR, which is typically the band and snare technique, and a small amount of gastric and duodenal EMR. And again, in the esophagus, it's about a 90-10 split between EMR and ESD. In the stomach, it's a little more. It's about 50-50 ESD and EMR. And in the duodenum, it's exclusively EMR. I don't do ESD in the duodenum.
Pretty aggressive doing ESD in the duodenum. So tell us how you got your start in this. I mean, obviously, you didn't learn EMR and ESD as a fellow. You must have learned in the years since you completed your training. What attracted you to this, and how did you get into it?
Yeah, that's right. And this is increasingly the issue for this rapid pace of innovation in endoscopy. Techniques come out that didn't exist when we were in our training, and this was true for EMR for me. I finished my training in 1998, and we just were starting to see a few reports of EMR. We hadn't seen any ESDs reported, and so when I started my first practice job then at the Medical University of South Carolina, where I had just finished an EUS and ERCP fellowship, I didn't have any training in EMR. We started to see a few cases of gastric polyps that we would do a band and snare with an old-fashioned just band and snare,
esophageal bander,
dedicated, right, and a few cases of injection and lift and snare. But for the most part, we taught ourselves. We watched a lot of videos from Japanese experts. I saw them do it at some courses. But it wasn't until I came to Mayo in 2003 and we're really starting to get increasing demand for management of flat colon polyps that I decided I wanted to go and get some dedicated training. So at that time, there were really two people publishing a lot of the colon ESD work, Dr. Yahagi and Dr. Saito, both in Tokyo. And so I arranged to get a short sabbatical to go over for a month to Tokyo and spend a month there just watching cases and doing some ex vivo labs with them. And then I came back and spent another year in our ex vivo and in vivo animal lab, just trying to get comfortable with the techniques before we started doing ESDs. And this is ESD.
Right,
EMR, we largely taught ourselves because it was largely just an extension of saline lift polypectomy. So we really just taught ourselves and started with small lesions and worked our way to larger and larger and more complex lesions.
So how was it doing your first ESD alone in America?
It was long, and they're still very long cases.
I'll bet it was.
And it is still the procedure that causes me the most anxiety, just because of the length of the procedure and the risks associated with it. So it's certainly anxiety provoking. I don't look forward to those cases, to be honest with you. I do them because I think it's a good curative procedure in a difficult situation where a patient's facing surgery otherwise. So,
right.
But they are quite long and tedious, and it's a different level of concentration than most endoscopic procedures take less than an hour, and this was really one of the first endoscopic procedures that got into the 2, 3, even 4+ hour long procedures, and we weren't trained, like a transplant surgeon to keep your focus for 4 hours. We really had to retrain to maintain a high degree of concentration for such a long period of time.
And what would you say the average length of an ESD is in terms of time? They can't all be 4 hours.
It's about 2 hours. Yeah, it's about 2 hours is our average length. We book them in a way that I typically book them in my last 2 slots of the morning where I have a lunch break, or my last 2 slots of the afternoon where there's nothing to follow it, because it is quite unpredictable how long they can take. And I don't want to feel pressure that I've got a case immediately to follow.
Mm-hmm. And I assume you're using general anesthesia or MAC for these cases?
I use general anesthesia for upper, just because it's airway management in such a prolonged procedure can be an issue. For lower procedures, I typically use MAC anesthesia. We don't do any of our complex procedures anymore with conscious sedation.
Right. And then how do you, I'm just sort of curious, you're doing such a long case, how do you bill that? Obviously, are you doing it based on the add-on codes for additional sedation time, or are you doing a modifier 22? I'm just sort of curious how, obviously I'm sure the Mayo Clinic, doesn't want you to, bill an EGD for a 3 or 4 hour procedure. How does the billing and the coding work?
Yeah, as you know, there is no dedicated CPT code for ESD, so we use the EMR codes typically, which now does have a dedicated code. And we often, if it really goes more than 90 minutes to 2 hours, we'll use the 22 modifier and write in special justification why it was a unusually long and complex case.
Mm-hmm. It is interesting to see how things have moved so quickly in the past couple of years. I was a couple of years behind you. I finished my training in 2002, but I remember, even when I was a fellow, I remember C.J. Gustout, talking about they were playing around with solutions to increase the time of a submucosal injection to give a polyp a longer lift so they could do bigger polyps. They were thinking about this way back then. And again, everybody learned saline-assisted lift and hot snare technique as a fellow, even back when you and I were fellows. But I think the kits have really, really simplified things and helped a lot of people who maybe would be a little afraid of some of these procedures jump into some more mainstream EMRs. We have a couple of these kits on our shelf, and I've used them all, and I don't know what you think. I find them incredibly easy and helpful to use.
Yeah, I think a lot of things have made it a little bit easier over the last 10 years. I think the solutions have gotten a little bit easier. There's a variety of viscous solutions, either things that people mix themselves, and now actually there is a dedicated approved viscous solution for EMR that's off the shelf. The snares, we've got a nice selection of dedicated stiff snares that were really developed for the purpose of EMR. And I think in the upper gut and actually in the rectum too, the dedicated band and snare tools have really been a huge bump forward. I didn't appreciate that initially, how that would transform, particularly Barrett's practice, having a device that people were very familiar with, a band ligation and a snare, and just simply combining them. And they really made it technically much easier to do band and snare type EMR.
I mean, they combined two techniques that people were comfortable with already into essentially a third technique.
Right, and even the lift and cut or lift and snare technique, I think almost all busy endoscopists are doing some saline lift polypectomies, and EMR really is no different fundamentally than a saline lift polypectomy. It's really getting a couple of minor technical things worked out in terms of the multi-piece resections and how you lay the snare down with the second and third and fourth piece. And then the other major issue is dealing with the adverse events, because it does have higher risk of both bleeding and perforation. And I think as physicians, as medical doctors like we are, for the most part, we do have a few surgeon endoscopists, but perforation was always this greatly feared complication because it always meant surgery. And now with devices and techniques to close perforations, it's made the actual EMR or ESD procedure far less stressful and far more manageable, because that fear of perforation isn't so great because we know we can close almost all of it.
Right, and there's also, there's a difference between a perforation of the colon and a patient who's sent home, eats, and soils their abdomen, and a perforation that you see right there yourself that you just did during the procedure, that that abdomen behind that little hole is clean. Those are two completely different animals, and I think people, when they hear the word perforation, they often think of the former, but it's usually the latter in a procedure. Do you lean more heavily on clips or suturing to try to close, if you, God forbid, get a perforation?
We typically use clips. Obviously, a through-the-scope device is a lot easier to use for most people, especially if you're in the proximal colon, where you don't want to have to pull the scope all the way out and change to suturing. We also have the over-the-scope clips dice.
But you do have to remove the scope for that as well.
Right. So we generally will try clips first, and it tends to be based on the size. Fortunately, perforations are still relatively rare, so I haven't had to have a lot of experience with closing perforations, but the experience we have had is that almost all of them, under 1 or 2 centimeter defects, and most of them are well under a centimeter defect, can be closed with clips using these what many refer to as the zippering technique, where you really start right at the corner of the lesion and put closely stacked clips together to close the defect. Even if the actual defect is broader than the clip jaw, you can zipper it closed by starting at the edge of the lesion.
Yeah, you can close some pretty big defects using the zipper technique. It's pretty impressive. I've played around with it myself, and some of the videos you can see online are really, really impressive. So now you went to Japan. Not everybody has a month to go to Japan. Let's say you're talking to a gastroenterologist who's, 5-10 years out of training and is interested in learning ESD, really can't take a month to fly to Tokyo. How would you suggest, they approach the question of, A, should you be doing ESD? And B, if you want to do ESD, how do you go about learning?
Yeah, it's a really relevant question. We get this asked to us quite often. I think the ideal candidate to learn ESD, first of all, is someone who's already doing a fair amount of EMR and has, mastered the techniques of injection, using devices to incise through tissue, and also getting pretty comfortable with managing the complications, the bleeding and the rare perforations. I think it is possible to learn the technique without having to travel to Asia, and I say Asia because now it's not just Japan, it's Korea, China are all doing very high volume ESD. I think the options for learning right now for someone who's already pretty comfortable doing EMR, certainly there's some courses both in the United States and not too far away. There's some courses in Latin America. Peter Dragonoff at the University of Florida has an excellent course every year. The ASGE has typically had an ESD course, often bringing in the Japanese experts. And then starting a little bit like I did, I think starting in an ex vivo lab, working with ex vivo's pig stomachs or similar tissues, you can certainly master many of the cutting and closing techniques. You can't manage the bleeding issue. And then where feasible and with very appropriate justification, using live animal training, because that's really the only way to simulate the management of bleeding, but that obviously should be limited where only necessary. But I think you can get a reasonable amount of training without having to spend a month in Asia. And the other tremendous resource now are videos. We didn't have video GIE. We didn't have YouTube 10 years ago, and you can find hundreds and hundreds of high-quality videos on both of those resources.
It is amazing, the volumes. Like, I totally agree with what you say. It's very striking to me, the volumes of ESD that they are doing in Asia. I imagine most of it is early gastric cancer, but there people in America talk about doing hundreds of ERCPs or hundreds of EUSs a year, and there's no shortage of people throughout Asia who are doing ESD at that volume. For some people, it's essentially all they do.
Yeah, that's right, and I think there are different reasons for that. One is the high incidence of early gastric cancer in Asia, so they certainly have more cases to do, and there's a large population awareness of stomach cancer. So patients are asking to get screened. Some countries have formal screening programs. I think the other issue is that, particularly in Japan, and I think now increasingly throughout Asia, there really is a different approach to early neoplasia, which is shifting away from piecemeal resections to en-bloc ESDs for essentially all flat early neoplasia. As you know, there's even some terminology differences between what we call dysplasia and in Asia is often called cancer. So an intraepithelial neoplasia in the West is called high-grade intraepithelial neoplasia if you use the World Health Organization or the Vienna classification. But in Asia, that's often referred to as cancer. And the Asian guidelines often suggest that you need an en-bloc resection of such a lesion. Now, we can argue whether that's clinically appropriate or not, but there is some cultural difference between the approaches to these early neoplastic lesions that in Asia tends to drive a wide field en-bloc resection, which often requires ESD, whereas in the West we would often feel quite comfortable doing a piecemeal resection of such a lesion.
Right. One of our former, so you know that I'm the GI Fellowship Director here, and one of our former fellows, Takayuki Suzuki, finished his training with us and is now back in Japan doing his practice. And he said recently to me that the most common procedure he does overwhelmingly is gastric cancer screening. I think he said it was about half of all endoscopy that he does. And it's just, it's him and everyone else in GI in Japan. It's such a mainstay. And he's he's not doing ESD, but I mean, it's not uncommon from what he was saying for them to find a lesion of concern and have to send it up the food chain to an ESD expert. It was like,
by the way, there is an opportunity for some of that in the United States. You know, we have approximately the same number of gastric cancers in the United States as we do Barrett's-associated adenocarcinomas, and yet we spend a great deal of time screening and surveying and treating Barrett's-associated lesions. But we don't do that for stomach cancer, even though the incidence is about the same. You know, particularly in high-risk populations, which are, you know, often first-generation immigrants from high-incidence countries, and those who have chronic atrophic gastritis, especially those with intestinal metaplasia of the stomach, I think there's a strong argument for doing early gastric cancer screening in the United States and in the West. And Juha Wong wrote a nice piece in GIE last year on this topic, and I think it is an underappreciated value that we should be considering in some of our patients in the United States and in the West in general.
Right, and in the U.S., when people get intestinal metaplasia of the stomach on a biopsy, they sort of roll their eyes and groan because, A, they're not usually 100% sure how to manage it, but they know that it requires some sort of long-term surveillance. And the other thing is, I will tell you, you know, I'm at a large cancer hospital out here in Salt Lake at the Huntsman Cancer Institute, and I mean, we're very, very, very busy, like the GI group and the GI surgeons and the GI oncologists. I mean, we're bursting at the seams, but, you know, in a whole year we may see one or two early gastric cancers. Unfortunately, almost all the gastric cancers we see are, you know, very, very advanced, large, bulky lesions. Linitis plastica is not uncommon. So I agree with you. I think we're seeing those large lesions because there is no screening going on, and all these early gastric cancers are going completely undetected, and we're seeing people when they're manifesting with gastric outlet obstruction or, you know, nausea and vomiting from linitis plastica from an indescensible stomach. But there's very, very few people who are working outside of dedicated high-risk clinics who are doing any real screening like that in the U.S.
Yeah, I think you're right. The other issue is I think we haven't necessarily trained our eyes in the U.S. to recognize early gastric cancer. I think there are some cases. We certainly do a lot of upper endoscopies, and we look at a lot of stomachs in the United States, but we're not necessarily looking for early gastric cancer. And I am amazed when I travel in Asia or go to a course or see a video that, you know, a Japanese or Chinese expert who does an endoscopy and you know, says, do you see that early cancer there? And I really have to squint my eyes sometimes, and at first I don't believe it. And then they get closer and they look at it with enhanced endoscopy and zoom, and they're right. You know, they're detecting early gastric cancer, you know, much like we've retrained our eyes to detect serrated lesions in the right colon. I think there are some lesions almost certainly that we're not seeing that are visible in the West, and that is an opportunity to offer patients curative procedures like ESD.
Right, and I do agree with you. I think it's very easy in America to blow through an EGD quickly. You know, people view it as a chance to get ahead on their list. If they're behind from doing a bunch of colons, you can do it fast, take some biopsies for H. pylori or the duodenum to rule out sprue, and you're done quickly. But you know, it's sort of like is analogous to what people talk about in the Barrett's literature, like how many minutes should you be looking in the esophagus at Barrett's? How carefully should you be looking? Should you be staining? Should you be using NBI or other assisted technologies? And I think even that is just sort of now slowly starting to permeate people's consciousness that you have to slow down and really, really look at Barrett's. And I don't think people are looking in great detail at the stomach. If it looks good on sort of white light as they're moving through, I don't think most people are spending a ton of time on it in this country.
Yeah, I think that's probably right. I think we tend to focus a lot on really making sure there's not an ulcer in the stomach or the duodenum, and then look for Barrett's. But you know, it does take a meticulous exam, just like we're now doing in our colonoscopies in the right colon. You have to wash the stomach really well. If there's some bubbles, use some simethicone. I don't think you need any of these special agents to do a good exam, although sometimes just some simple acetic acid or vinegar can be quite helpful. remove some mucus and provide some contrast. But usually just a good washing with the water jet and a careful look. Typical Japanese endoscopy, they'll take 40 photographs in the stomach. Each segment of the antrum, the four-ring retroflex view. So it gives you an idea how much time they're spending.
Right. There's very, very few people in the country, in the U.S., taking 40 pictures of the stomach in an EGD. You had mentioned acetic acid. What strength do you use? And do you do it through a spray catheter? How do you use acetic acid if you want to use it, like, for example, to look at the stomach lining more carefully?
Yeah, so acetic acid is obviously very inexpensive, widely available. It's just vinegar. We use a 1% or some of the literature will say 1.5% acetic acid. Hospitals routinely stock this because gynecologists use it for cervical staining.
Sure.
So our pharmacy stocks acetic acid routinely. So in the stomach, I do the first thing I do is I wash all the visible material and bubbles off with some water and simethicone. And then if I do apply a contrast agent like acetic acid, I like to use a spray catheter, and a lot of that is just the angles of the stomach, particularly the antrum, is very non-dependent in a patient who's lying on their left side. So to spray uphill, essentially, you really have to aim a spray catheter pretty well. So I do spray starting at the pylorus, lesser curve on the non-dependent side, and I just work my way backwards as I pull back up to the GE junction. It takes just a minute or so to spray it. You can, in theory, do it just through just squirting it through the water or the accessory channel.
You'll probably get a lot of pooling with that, though.
Yeah, you have to aim pretty carefully, and in my experience, you don't get quite as even a coating as you do. But it is very inexpensive, so it's not a big deal to use a bit more if you have to.
So let's shift from the stomach back to the colon for a bit. You said at the beginning of the podcast that you're doing EMR in the right and ESD pretty much only in the left in the colon, correct?
That's right.
So tell us your thinking on that.
So there's two reasons that drive that. One is the risk, and the second is the consequences of being wrong about doing an EMR. So the risk issue, the main risk of ESD is perforation. But if you perforate below the peritoneal reflection, there's usually pretty minimal clinical consequences of those. We do try to close those if I'm doing an ESD in the rectum and we have a perforation, we do try to close it with clips or suturing or over the scope clips. But even in the event that you can't get a secure closure, a small perforation below the peritoneal reflection doesn't usually leak gas into the abdominal cavity and frequently will close by itself. Right. And
I've had surgeons tell me at more than one institution that I've been at that when they do a transanal full-thickness resection on a T1 rectal cancer that they don't even close it. They just take the lesion out and leave the hole to close secondarily because they know that they're safe in the perirectal fat. It's the exact same idea.
Yeah, that's absolutely right. The one exception is if someone's had some colonic surgery, and we've had this come up a little bit in some of the subtotal colectomies, or if it's an IBD patient and they've got a pouch, the peritoneal reflection is no longer there. So that is one exception to that rule. So that's the consequence or the risk issue. It's also just technically easier to work in the rectum. You can use an upper scope. You can retroflex very easily. You can exchange scopes and devices very quickly without having to reintubate. The other is the consequence. So, ESD, the true value of ESD is when you've got a superficial carcinoma, particularly a superficially invasive submucosal carcinoma. So one that goes, about 1,000 microns or a millimeter or less into the submucosa. That's a lesion that if you take it out piecemeal and the pathology comes back superficially submucosal cancer, the current guidelines say that patient has to go for surgery, a completion colectomy or proctectomy. Whereas if you've done an ESD, that would be considered curative of such a lesion. And the bottom line is we're not very good at predicting which lesions have superficial submucosal invasion. You can look at it and apply all the classifications, Paris classification, the NICE classification, the JNET classification. Even in the very best of hands, and even out of the Japanese literature, we're just not very good at making that prediction. So at the end of the day,
those Japanese hands are ultra high volume,
right? So
very experienced eyes.
Right. You take your best guess, and there's a pretty reasonable chance that we might be incorrect. So if you do a piece, if you think it's non-invasive or just a mucosally invasive lesion, and you do a piecemeal EMR in the right colon, and if you're wrong, the consequence is that the patient gets a laparoscopic right hemicolectomy, which is a pretty low morbid, low risk procedure. However, if you do it in the rectum and you're wrong, the patient gets a low anterior resection or worse.
Which is a big deal.
Perineal resection, often involving at least a temporary, if not a permanent colostomy. So the consequences of being wrong in the rectum are much greater than being wrong in the right colon in terms of what happens next.
And do you think most people feel the same way as you do when thinking about those lesions and the consequences of doing one or the other in the right or the left colon?
Yeah, I think this is starting to get written into the guidelines. So actually the most recent ESGE guidelines, which was published in Endoscopy last year, our sister journal, they had a really nice review of this topic. And they did come out and say that there should be a different consideration for rectal lesions than proximal colon for exactly this reason, that both the consequences of what happens if you incorrectly remove it piecemeal, as well as just the technical difficulty, both would favor ESD where there's any reasonable chance that it's an invasive lesion. I mean, typically that's size-based, typically more than 3 centimeters or so would suggest that it has a chance of being invasive.
Thinking about working in these spaces, do you see any new technologies coming that you think will change these procedures or make them more accessible or easier to do in the next couple of years? Anything big or mostly refinements of existing technologies?
Yeah, I think we certainly are seeing every year we're seeing refinements of existing technologies, and that I wouldn't underappreciate how important those can be. One is we talked earlier just about lifting agents. So, right now we have to mix a concoction of different things, usually a blue agent, a viscous agent, some saline, and some people like these epinephrine. A lot of places don't have the capability to do that easily. So now we actually do have an injectable, off-the-shelf, approved, pre-made solution. So that's one step forward. The other thing we're seeing, the knives, we're getting increasing number and variety of knives, and particularly some of the small insulated tip knives, which allow you to cut pretty quickly with that insulated tip, preventing injury to the deeper layers. We're also seeing several types of scissor-type knives, some of which have insulated outer walls so that you can close the scissor essentially and cut with very minimal risk. So those have made it quite a bit easier. And then a third technique that we've seen starting to gain some traction are these string-assisted, where you make your incision around the perimeter of the lesion, and then you take a little through-the-scope clip attached to a suture and clip that on, and it provides traction, which has always been a major limiting factor of all endoscopic procedures. It's a single.
Right. The surgeons live in a world of counter-traction. We don't.
Right, and that string, even though it seems to be along the same axis as the scope, it actually isn't the exact same axis, and you can pull, even if you just apply some tension either through the rectum or through the mouth with the string attached to a clip, you do often get a nice tension, and this is especially true in the rectum and in the GE junction. And then I think the last technique we've seen that has made this quite a bit easier is the so-called tunnel or pocket. techniques. Traditional ESD, you make a circumferential incision, and then you start to just kind of whittle your way through the base of it from one side to the other. But the way the tissue, because we don't have that traction, the tissue you're completely dependent on gravity. The tunnel or pocket techniques typically start, and these really came out of the POEMS literature, where you just make a small entry incision and often make a small exit incision on the other side of it. And then you just create a tunnel underneath the lesion. And the tension that is held within the tunnel, because the tissue on either side of the tunnel is still intact, provides some counter tension, and it makes the cutting quite a bit easier. So there's been quite a few papers now using these tunneling techniques that have shown that the speed of the procedure is quite a bit faster.
And I imagine, too, if you become facile with POEM, that's probably a very, very easy leap to make, to do these tunnel techniques underneath lesions.
Yeah, and we are there are some devices in the pipeline that are starting to approach surgical type tools. There's some devices that are over tube-like devices that currently allow you to manipulate the tissue with an over tube-like device and create a working space. It's a clean space. It's essentially a double balloon system that provides a working space where you don't have effluent coming down from the proximal valve, and also can provide some counter traction. And I think we're going to see more and more devices like that, where there is actually an accessory channel that's independent of the scope, so you can sort of apply traction. You can grip
sort of
something,
an extracorporeal channel, as they say.
Right.
That's real. I'm telling you, it's a very, very exciting time for it. I mean, it just seems like we've gone from no papers about these topics to a few papers to every issue of GIE. We have a couple of papers on this because there's so much interest and so much work being done. We should wrap up in just a second. Any last thoughts for our listeners on EMR and ESD in 2018?
Well, I think one of the things, although this has been around a long time, I think we still have a long ways to go. We've had several articles, both in GIE and in other journals, that have shown that the proportion of patients that are getting colorectal surgery for non-invasive polyps has not actually declined in the United States. And so there's still the majority of patients with such lesions, particularly a large flat or lateral spreading polyp, are still getting referred for surgery. And I think we really need to continue to educate patients and referring physicians that this is a viable option. And then lastly, there's some important things that physicians can do when they find these lesions that can at least avoid further difficulty down the road. And two things make it considerably more difficult to do any subsequent resection. One is injecting a tattoo material directly under or immediately next to the lesion. The carbon particles are very fibrogenic and make any subsequent resection difficult. The other is any attempted resection. Often we see reports coming in that they just did a quick sort of diagnostic polypectomy of part of the lesion or some extensive biopsies. That makes any resection difficult. So I would encourage physicians, when they find such a lesion, not to use any snare method, even extensive biopsies, and certainly not to inject tattoo anywhere near the lesion.
Tattoo near it or around it, maybe one on each side, a centimeter or two away instead.
At least a couple of centimeters away, and I prefer opposite wall myself, just so it doesn't leach under the lesion and fibrose the edge of it.
And it does leach underneath much further than you think.
It does. I've seen a lot of photographs taken at the time of the procedure where there was, they injected a cc of tattoo, a centimeter away, but by the time they come for the procedure, it's fully underneath the lesion.
But it bespeaks a bigger topic, and this is a phrase that I've said many times. Like I feel like I'm a beneficiary of my training, but I'm also a bit of a victim of my training. Like your training is sort of frozen in time, and it takes a lot to sort of break out of the patterns or the sort of flow algorithms that you've used for years and years and years. for a lot of people, I imagine, whether they're a GI doc or a surgeon or a family practitioner even doing colonoscopy, they see a polyp that they think is too big, and their immediate reflex is call a surgeon. And the surgeon's not going to argue with that. You know what I'm saying? Like, they're just going to say, okay, great, not a problem. I'll do a right hemicolectomy. Thank you so much. Right? And unless there is somebody in that mix of people taking care of that patient, the GI doc, the surgeon, someone to say, hey, maybe we should send this to a tertiary center and see if they could get it out, it's just not going to happen. And I think that's part of what explains that rate of large polyps going for going for surgery still. It reminds me of, and I've talked in this podcast before about how one of my favorite things to do is endoscopic gallbladder drainage. And it's almost the same problem because, the surgeons get called to the ER to see somebody with cholecystitis. They say this is not a good surgical candidate. And then, nobody thinks, and the call is placed to IR, and somebody gets a PERC chole, which is a very morbid procedure, and many of those PERC chole tubes are destination. People have them in for months, if not forever. And, it is very, very hard to sort of interpose in that algorithm, hey, maybe there's an endoscopic approach here. It's the same dilemma, just with a different procedure on the end of it. But, most surgeons, they won't even think to send somebody for a PERC chole in the same way that a lot of people wouldn't even think to send somebody for a hemicolectomy when there's an endoscopic option. You do what you've done for the last 20 years. It worked fine so far. I'm not going to change, but doesn't mean it's the right thing to do in 2018.
Yeah, although the availability of good quality medical information on the internet is really changing that. I get about half of my referrals from, I call it Dr. Google. Somebody was told they needed surgery. They went on the internet and they found out about EMR and they referred themselves for it. And those, I must say, that this is really the most satisfied patient I have in my practice is somebody that
you saved them.
Needed surgery, come in, and especially in the esophagus, who, the difference between an esophagectomy and an outpatient EMR, go home the same day, is such a dramatic difference. And it's a little bit less so in the colon, but still, people want to keep their colon in.
Right. God bless Dr. Google, if I'm reading it correctly, in this context at least.
Yeah, and I think,
sometimes Dr. Google is less than helpful, in all fairness.
You're right. You're absolutely right. But in this case, I think more information available to the patients is allowing them to seek these out. And it certainly doesn't, it doesn't bode well if a patient finds out about it from Dr. Google instead of their referring physician.
Right. Well, sure.
Particularly pleasant.
Right. As they, did the doctors that they're talking to already just, you're always supposed to tell them the risks, benefits, and the alternatives to any procedure. You always wonder where all those alternatives discovered or discussed. Sometimes that's hard to do. We should probably wrap there. I want to thank again Dr. Wallace for being our guest here on this month's GIE podcast. Mike, any parting words for the audience?
I just want to thank them all for their interest in GIE. It's been we very much enjoy getting comments from readers, from authors, and also want to thank you, Doug, for doing these wonderful podcasts. I tend to listen to them in my car when I've got a longer drive, or on the treadmill if it's the rare cold day in Florida when I don't get to run outside, and so I really enjoy the whole process. Thank you.
Thank you. And we'll be back next month for another GIE podcast. Thanks, everybody. Thank you, Mike.
Thank you for listening to this podcast. Gastrointestinal Endoscopy publishes original, peer-reviewed articles on endoscopic procedures used in the study, diagnosis, and treatment of digestive diseases. Connect to the journal online at www.giejournal.org.